Pathology of skin lesions. Introduction. Histopathology is the diagnostic gold standard. It must correlate with clinical appearance. Pattern, cell type and location are its key elements. Biopsy basics. Biopsy could be punch, shave, or excisional types. Technique affects the diagnosis quality. Use formalin as a fixation and mark the orientation or margins. Choosing the type of biopsy. Shave biopsy is used in actinic keratosis, seborrheic keratosis, verruca BCC or SCC. Punch or excision can also be considered in BCC or SCC. In blistering disease, punch or deep shave edge of blister is often done. Punch biopsy is done in contact dermatitis, connective tissue disease, mycosis fungoides, vasculitis, and granulomatous process. Atypical nevi to deep shave, punch or excision. Paniculitis to punch, minimum 6 mm or ellipse. Verhoef van Giessen VVG stain. Demonstrates elastic fibers. They appear black, useful in vascular pathology, aneurysms, vasculitis. Toluidine blue. Stains mucin blue. Shows mast cell granules metachromatically, reddish-purple against blue background. Masson's trichrome. Differentiates collagen and muscle. Collagen is blue or green, smooth muscle and cytoplasm is red. Great for fibrosis versus smooth muscle pathology. Letter stain. Highlights mast cell cytoplasm as red, used in mastocytosis. Periodic acid Schiff, PAS. Detects glycogen and carbohydrate-rich structures. Also stains fungi cell walls, red or magenta. Useful in glycogen storage diseases, candidiasis, etc. Alcyon blue. Stains acid mucopolysaccharides, example, mucin blue. Helps in distinguishing acidic mucins from neutral ones. Colloidal iron. Also demonstrates acid mucopolysaccharides, appears blue. More sensitive than Alcyon blue for acidic mucins. Mucicarmine. Stains mucopolysaccharides, especially epithelial mucin, pink to red. Very useful in identifying Cryptococcus capsule. Congo red. Classic stain for amyloid, appears red. With polarized light apple green birefringence, gold standard. Thioflavin T. Another amyloid stain, appears yellow to yellow-green fluorescence under UV. More sensitive than Congo red, but less specific. Crystal violet, used to detect amyloid. It shows a red-purple metachromatic reaction, helping in amyloidosis diagnosis. Prussian blue pearl stain, highlights iron deposits in tissues, example in hemochromatosis, hemosiderosis, as deep blue granules. Fontanamasson demonstrates melanin. The pigment turns black, useful in melanoma and pigmentation studies. Von Casa detects calcium salts. Calcium appears black. It actually stains phosphate, but indirectly marks calcium deposition. Alizarin red, another calcium stain. Deposits appear orange-red, often used in bone or tissue calcification. Oil red O fat-soluble dye for neutral lipids and triglycerides, shows red droplets in frozen sections. Sudan black also demonstrates lipids, especially phospholipids and neutral fats, appears black. Gomery methenamine silver GMS highlights fungi by staining their cell walls gray-black on a green background. Zeal Nielsen or phytic acid fast stain, used for mycobacteria, example Mycobacterium tuberculosis, Mycobacterium leprae. Organisms appear red against blue background. Auramine rhodamine, a fluorescent stain for mycobacteria. Organisms fluoresce red-yellow under UV. Warthin starry, a silver stain for spirochetes, example Treponema pallidum. Organisms appear black. Giemsa multipurpose. Stains myeloid cells and mast cells, blue cytoplasm, purple granules. Useful for parasites like leishmania and histoplasma. Choosing the site to biopsy. Brand new lesion is the best site for biopsy, but exception in blistering disorders. Submission of the biopsy. Formalin, ethyl alcohol, and Michel medium are often used. General histologic layers. Are epidermis, dermis, subcutis. Evaluate all layers for inflammation or neoplasia is essential. That is reactive units of skin. The superficial reactive unit SRU comprises the epidermis E, the junction zone J, and the papillary body PB or papillary dermis, with the superficial microvascular plexus. The dermal reactive unit DRU consists of the reticular dermis RD and the deep dermal microvascular plexus DVP. The subcutaneous reactive unit S consists of lobules L and septae SEP. A fourth unit is the appendages. A is the hair and sebaceous glands are the only appendages shown. HF is the hair follicle. Epidermis. Disturbances of epidermal cell kinetic may occur as acanthosis and atrophy. Disturbances of epidermal cell differentiation occur as parakeratosis and dyskeratosis. Disturbances of epidermal cohesion. Spongiosis and acantholysis. This is a picture of acanthosis. And this is atrophy, spongiosis, and acantholysis. Pathologic reactions of the entire superficial reactive unit. Spongiotic dermatitis, psoriasis, interface and lichenoid dermatitis, and subepidermal blistering processes. Patterns of inflammation. Interface, lichenoid vacuolar. Spongiotic, intercellular edema. Psoriasiform, regular acanthosis. Perivascular, often drug-related. Vesiculobulous, intra versus subepidermal. Interface dermatitis. Vacuolar basal alteration. Apoptotic keratinocytes, CIVAT bodies. Seen in lupus, dermatomyositis, drug reactions. Lichen planus. An acanthotic epidermis with a band-like lymphocytic infiltrate that approximates the dermal-epidermal junction. Spongiotic dermatitis. Intercellular edema. Vesicle formation possible. Common inflammatory cell is eosinophils. Seen in eczema, contact dermatitis. Spongiotic dermatitis. There is accumulation of fluid in the epidermis leads to formation of an intraepidermal microvesicle. Psoriasiform dermatitis. Elongated reedy ridges. Thin suprapapillary plates. Monroe abscesses which is neutrophils in stratum corneum. Classic in psoriasis. Psoriasis. There is uniform thickening of the epidermis with elongate reedy ridges and a diminished granular layer. Vesiculobulous diseases. Intraepidermal, pemphigus vulgaris. Subepidermal, bullous pemphigoid. For definite diagnosis, immunofluorescence often needed. Bullous pemphigoid. There is subepidermal blister formation associated with an eosinophil-rich infiltrate. At the edge of the blister, eosinophils align at the dermal-epidermal junction. Reticular dermis. Pattern evaluation involved angiocentric pattern, periadnexal pattern, and diffuse or nodular pattern. Composition of the infiltrate are lymphocytes, neutrophils and eosinophils, and granulomatous reactions, histiocytes. Angiocentric pattern. Inflammatory cells are seen primarily around small vessels in the dermis. Parafollicular pattern. In this example of folliculitis, inflammatory cells surround a follicle. Nodular pattern. Dense aggregates of inflammatory cells are present in the dermis. Eosinophils. The nuclei are bilobed and the cytoplasm is bright pink and granular. The lymphocytes have small dark nuclei and scant cytoplasm. Granulomatous inflammation are the histiocyte aggregates, with or without necrosis, seen in sarcoidosis, tuberculosis, leprosy, foreign body reactions. Granuloma. This foreign body granuloma shows an aggregate of lymphocytes, histiocytes, and multinucleated giant cells forming a nodule. Higher magnification. of epithelioid histiocytes and foreign material, black pigment. Granuloma annulare. In granuloma annulare, histiocytes and giant cells surround a zone of hypocellular collagen that shows few to no nuclei. Paniculitis. Paniculitis is the inflammation of fat. Subcutaneous fat has lobular paniculitis, example erythema nodosum, and septal paniculitis. Always look for vasculitis, necrosis, granulomas. Xanthoma cells. The cytoplasm is enlarged and shows a vacuolated, bubbly appearance. Fibrous dermis and extracellular matrix. Sclerosing processes. Faulty synthesis or cross-linking of collagen. Alteration of elastic fibers. Dermal alteration due to endogenous and exogenous materials. This show actinic solar elastosis. The superficial dermis show many gray-colored elastotic fibers from chronic sun damage. In the lower portion of the photomicrograph, the collagen shows the normal pink color. Tattoo. Foreign substances can be deposited in the dermis. Tattoo pigment is seen here as coarse clumps of black pigment in the superficial dermis. Neoplastic disorders. Epidermal origin. Keratinocytes. Melanocytic. Adnexal. Dermal origin. Fibrohistiocytic. Vascular origin. Neural origin. Smooth muscle origin. Neoplastic disorders. Verruca vulgaris. Verruca plana. Condyloma acuminatum. Seborrheic keratosis. Squamous cell carcinoma. Keratoacanthoma. Basal cell carcinoma. Trichoepithelioma. Trichoblastoma. Syringoma. Sebaceous tumors. Common nevi. Dysplastic nevi. Spitz nevi. Melanoma. Dermatofibroma. Dermatofibrosarcoma protuberans. Atypical fibroxanthoma. Pyogenic granuloma. Angiosarcoma. Neurofibroma. Schwannomas. Leiomyoma. Special stains and techniques. Periodic acid Schiff and Gomery methenamine silver are used in fungi. Acid-fast bacilli stain is used in mycobacteria. Direct immunofluorescence is used in immunobolus diseases. And immunohistochemistry in tumor markers. Summary. Histology is critical for diagnosis because it provides the tissue architecture and cellular details that allow us to differentiate between disease entities. Recognizing major histologic patterns is often the first step toward narrowing the differential diagnosis. But histology alone is not enough. Clinical pathologic correlation is essential. The patient's history, physical findings, and lab data must be integrated with the microscopic features to arrive at the correct diagnosis and guide management.